Good afternoon. Hi, Dr. Porter. How are you?
All right. How are you, Dr. Seetharamu?
I'm all right, too. So let's take these questions. I'm going to start reading since I presented first, and I think some of the first initial questions are for me. The first question is, was pathologic CR affected by PD-L1 level in any stage in Checkmate 816? Well, they did not present this data at this ASCO. I don't think so. However, it was presented at AACR, and regardless of PD-L1, there was a response, but it was, the percentage of PCR was proportional to the PD-L1. But they were all better than chemotherapy alone. So that was, I can get the numerical values, but they were definitely superior as the PD-L1 levels went up. Do you have any further information on that?
Not any of the numerical data, like you said. The thing that I'm suspecting is going to end up happening in trials like this, unfortunately, it's too late to go back and like do these things. Where if we know in the metastatic setting, PD-L1 1 to 49 needs chemo along with the IO, then why don't we just always, in all of our trials going forward, get a PD-L1, know if it's 1 to 49, and just give those patients chemo. If we're going to do like a neoadjuvant trial, then if you're 1 to 49, you should just have a chemo with IO option. I don't know if that makes sense, but there's some other trials, that are coming out, like the Empower 010, and we know about that, but everybody wants to see that 1 to 49 data. But we know it's not going to be as good as the greater than 50 or 60 or 70 up to 100%. We know it's not going to be as good. So from now on, designing those trials, why not just go ahead and get a PD-L1 up front, know if it's 1 to 49, we need to just add chemo along with it. So maybe instead of doing just neoadjuvant, atezolizumab, it's neoadjuvant atezo chemo.
Yeah, in this case, it was Nivo plus chemo. They did do the right thing, but they did record PD-L1 upfront. They also looked at tumor mutational burden, and if I remember correctly, they also looked at MRD at the end of treatment. So they did look at the liquid NGS at the end, and who cleared after neoadjuvant. They looked at all those biomarkers. So it was pretty well done. But if I remember correctly, I think in PD-L1 negative, I think it was something to the tune of 15%, whereas it was double if it was PD-L1 positive, anything above 1%. And PD-L1 1 to 49, which is the group that you were referring to, I think was 25%, and it was higher, like 40% or something, in about 50%. So you're right. I mean, like there are some trials just looking at immunotherapy alone in the neoadjuvant space. Perhaps, that's not, that's not, wise given the data that you presented.
Right. And so that's really kind of what I was referring to, not this trial, but any other trial where we're going to be in this space, that we should be doing it that way, because if we know, the 1 to 49 typically doesn't do as well. And then with tumor heterogeneity, even if the PD-L1's negative on the test, doesn't mean that they're not going to respond, So I don't think that in the future we should start excluding those patients if we find PD-L1 is negative. They should still be included because there's still a chance of response, and it's better than not giving a therapy at all, most likely. So it's going to be interesting going forward to see the results of all of these things.
Absolutely. So that brings us to the question, where in your clinical practice, will you offer neoadjuvant Nivo chemo to all stage 1B through 3A non-small cell, or only a subset? Well, it's very hard to answer this question. I think, it's relatively early to be talking about this right now, but I think that's where we are headed. We all, I think institutionally, many of us have clinical trials in this space involving multiple checkpoint inhibitors. So right now we are accruing to this trial. But I mean, I wouldn't just say Nivo chemo, but I think, immunochemotherapy seems to be all set to enter the neoadjuvant space. well, I would offer it if I see the patient 1B patient, but most of the time we see more advanced patients. The surgeons would not, usually I think institutionally, I think a stage 1B would get operated on. So I think we'll be looking at adjuvant space in those patients. But definitely for 3, I think for multiple studies have shown that more advanced, I think the stage 3 disease, there is no doubt there is benefit. I think that's where we'll get started, and then moving on downwards to earlier stages. What do you think?
I think that, institutionally, we're going to have to work with our surgeons and our pathologists to try to bring all of this forward, bring the PD-L1 testing forward. Now we're doing EGFR because of the ADORA data, but it needs to be PD-L1 based on the results from this year's ASCO. We should be doing all of that up front and just working really closely with the surgeons. Later on, we may see that there is actually a difference in adjuvant versus neoadjuvant using these therapies. And it may be better to get them in to see an oncologist up front. And then the other reason to consider doing that is because we see good responses, and I don't want to seem negative, but what if a patient doesn't respond? What if they progress? And if they're already connected to an oncologist and they're already being seen, then you can just work them through faster, as opposed to finding out, after a couple of cycles of therapy, and they didn't, or they progress, waiting on surgery, and the surgeon hasn't sent them to see an oncologist. It's better just to go ahead and set up with an oncologist. In our center, luckily, I do get to see some really early stage disease. We have some really great surgeons here. And even with a stage 1 tumor, they'll send them, because most times after surgery, I'm going to be the one following their scans, and I'm going to be the one doing their, their maintenance surveillance and everything. So I get a chance to see them earlier, as opposed to them just going straight to surgery. And we find out later that the neoadjuvant therapy was better. It made, the surgery easier. But usually for stage 3 disease, so probably not for a 1B or for like a 2 centimeter tumor with nothing else going on. That's probably pretty easy to resect most times. But to get there, and then later on, what are we going to find out for path CR? Does it really mean something for overall survival? And we don't know yet, but once we find that out, it may be better to get all of those patients treated up front instead of doing adjuvant therapy. So I'm interested to see what that's going to turn out to look like.
Yeah, I know. I think PCR correlating with survival, I think is the holy grail that we need to, for now we believe that is so, and I think that is that's probably the best way we can go forward. The next question is, I might have missed it, but what neoadjuvant chemo? They really allowed multiple agents along with platinum. So it was a platinum doublet versus chemo plus or minus nivolumab. Would it be advisable to withhold radiation concurrently with nivo chemo as neoadjuvant? If so, if there's a trial of nivo chemo versus chemo RT, I mean, there are trials of immunotherapy, chemo, and radiation. I'm not particularly sure if there is a nivo chemo RT trial, but I personally would hold off. This, I think chemo RT itself in the neoadjuvant space, has had questionable, has had controversial record in the past, and on top of that, if you're adding nivolumab, I mean, there is potentially higher risk for pneumonitis, higher surgical, complications. I'm not sure that I would be doing that. And this study did not look at radiation in addition to everything. I would not favor radiation along with chemo and nivo.
Right. I have, you've seen some data where radiation or immunotherapy after radiation will slightly increase risk of pneumonitis. And I've seen a couple of case reports with a recall type pneumonitis where they had radiation and got immunotherapy later, and they developed pneumonitis, but it was really only in the places that had been radiated instead of a generalized like pneumonitis. And so those were some pretty interesting case reports, but it was causing those patients to have to discontinue therapy and not, have that as an option in the future. So I don't know if it's, if we have enough data to say it's safe to do that. I would not necessarily radiate concurrently with the nivo plus chemo just yet. I think we don't know if we don't have enough data to call that safe yet.
And then the last question for me was, at least in the beginning set, was that I thought multiple chemo options with Nivo. In breast, we give full cycles of chemo, but in lung, they gave 2 to 3 in this particular study, they gave 3 cycles. They've typically given 2 to 3 cycles. I mean, the concern I think with lung is it's a faster growing tumor, you know, the aggressiveness of it. We want to get to surgery as soon as possible. We don't want to miss the opportunity for surgery. With breast cancer, I think things are mostly visible. You know, we know that we've had a lot of track record with neoadjuvant chemotherapy, but we are entering that space again with the new arsenal with regards to lung, and we can't really see what is going on inside. So typically, I think 2 to 3 cycles, you know, are fair. I think patients are hesitant to, and also surgeons are hesitant to wait longer than that. So I think that's why, for feasibility's sake, I think we've been doing 2 to 3 cycles. But that's not true for all the studies. There are some that go full 4 cycles, and there are some that only do 2 cycles. There are some that even did 1 cycle in earlier studies. So it's a plethora of, but this particular study looked at 3 cycles.
Right. I think platinum sensitivity in lung cancer makes it a little bit more responsive usually. And so after a couple of cycles, you've probably gotten as much, not all the time, obviously, but you've gotten some, you know, tumor reduction in size, and makes it probably a little bit easier for the surgeon. The problem is if there's any progression, you end up in real trouble, you know, as opposed to maybe a breast tumor that doesn't respond, you know, but it doesn't met out during that time. With lung cancer, if it doesn't respond, you really end up in trouble. You lose your opportunity for resection. And once the lungs start going down, you may even lose your opportunity, you know, to treat with systemic therapy if they get into trouble as far as respiratory status goes, other comorbid conditions that may also limit how much treatment you can give. So I guess you kind of need to be working on getting all of that in as fast as you can. And then this question, though, to me, it also made me wonder why we only give, you know, in the adjuvant setting, you know, why are we giving just 2 or 3 cycles? Because that, you know, 4 cycles, 6 cycles with small cell, I usually do 6 cycles. You know, I know some people who do 4 cycles. You know, the Empower 133 is the chemo plus the IO, but it's only 4 cycles of chemo. Depending on my patient's clinical condition, even in a setting like that, I'm usually giving more than 4 cycles if I feel like they can tolerate it. And so I guess we have some data that says there's no real difference between 4 and 6 cycles in settings like that, which is how we came to where we are. But we may find later that we should have been doing more. That's a good question.
Agreeing, yes.
Okay. So here I have, let's see. Make sure I'm at the right place. For PD-L1 greater than 50%, how do you decide between Nivo, Ipi, and chemo versus Pembro versus Cemiplimab? And that is a really, really good question. And I have to admit that I do not always get a great response with PD-L1 greater than 50% with single agent IO. And for that reason, I have decided in my own practice that I'm giving the chemo unless there's a reason not to give it. So if I have a patient with a PD-L1 of 50%, but they have a great performance status with great organ function and no other comorbid conditions, and I need to get a good response, I'm going to give the chemo, you know, with the IO. And even with the Nivo Ipi, I would give the Nivo Ipi plus chemo, so checkmate 9LA. I would do that over single agent IO only because I know that there's a higher likelihood of response. And when they do respond, it's great, but they don't always respond. And I've had a couple of patients who became really good friends of mine and didn't respond. Oh, that PD-L1's 90%. I know this is going to be great. And it didn't work out that way. And it's disappointing. And after it happens a couple of times, you don't want to get burned again. So I usually will go with the IO plus chemo unless there's a reason not to use the chemo. They have diabetes with pre-existing, you know, neuropathy, or they have pre-existing renal dysfunction, or, or the patient just says, I absolutely will not take chemotherapy, then I'll just use the IO without the chemotherapy. But even at PD-L1 50-60%, I'm usually giving chemo along with that IO, especially if you're going to use the non-LA, because that's only 2 cycles of chemo. And even the 189 is only 4 cycles of chemo. So, it's not a lot. I guess it's more chemo than I've ever had. So I should be careful in how I describe it. But for me, that I usually give the chemo, even in that PD-L1 high patient population, unless there's a reason not to. And then it says, why sotorasib could be given as a standard first line therapy. Why it could follow any first line therapy without obvious increase in toxicity if followed by immunotherapy, but given an EGFR inhibitor after immunotherapy can be problematic. So why? I think that I don't know that that's true, that there's not necessarily, as much problem, but I think one thing that I have seen and heard in clinical practice and when speaking with my colleagues is that the EGFR inhibitor after IO can cause some issues. It can be toxic. But I think that we learn how to look for that. And we've learned in some cases how to manage it. Even I've had even some of my patients go on to a little bit of, I will say, prophylactic steroid if I know I'm going to be changing them over. The other way to kind of combat that is to make sure we get our results from our, next gen sequencing before, or our comprehensive panels before going on to IO. But I think that in this clinical setting where you've progressed on standard of care, you want to get the KRAS inhibitor in. So it's more like I'm willing to take the risk because I need to treat the patient and I know that I have a good therapy. The other thing that's going to end up happening is we're going to start using that in combo, I believe, eventually with the first line therapy. And so like there's one trial that we're doing with IO plus, a TKI with chemotherapy. That's that the Merck 006 trial that's now completed enrollment, where you gave not cemiplimab, sorry, you gave pembrolizumab with lenvatinib and chemotherapy. And I had patients tolerate that just fine, tolerate the TKI along with the IO. So I think it's part of us kind of learning how to manage these side effects and learning what to look for. And they're not all created equal. So you may not get the same immune reactions after adding certain IO, certain TKIs after IO. So maybe the sotorasib or sotorasib is not the same as osimertinib as far as the risk for immune-mediated adverse events after adding the TKI. I don't know that we know that there's that they're equal, but from the trial, it looks like it's working out and it's safe. But I do believe we've seen some data where this particular one is actually a little bit better if you haven't had chemo yet. So I think that it ultimately will be brought up. But right now, the responses aren't as great as chemo IO. I think the duration of response is not as long. The overall survival is early. And we have that data now, but it's still early. But I don't think it's going to be as great as the combination. So probably it's better to bring that forward and add it with our therapy and get the long. But then what's going to happen? We're going to have mechanisms of resistance that we got to work around. I talked too much on that one, so I'll move on to the next question. Did you have anything to say about it, Dr. Seetharamu? Because I just
no, I think, to kind of touch the points, I think the molecules are not made the same. The other thing is, I think, what is the expression of EGFR or KRAS G12 in the normal tissues? That could go into the picture. Smokers versus non-smokers, benefit versus risk. I mean, definitely KRAS can occur in smokers, and high PD-L1 is usually associated with KRAS as well, and those patients respond very well, and we've had data from that. That was recently published that patients with KRAS mutations respond very nicely to checkpoint inhibitors. So I think it's a tilt of benefit risk ratio. And in patients with EGFR, they're usually never smokers. We've seen even without the TKI, we've seen hyperprogression, incidence of AEs much more profoundly in those patients. So I think it's both the molecule, the type of patients, and the fact that they don't glean as much benefit from IO.
Right, right. Okay, so next, do you need to approach squamous and non-squamous a bit differently with regard to immunotherapy? I would say no at this point. We have the keynote as well as the checkmate that all their squamous data, and so the only difference is the chemotherapy. But as far as the IO goes, I think it's okay to use what's already approved and what's out there. I don't think that we need to do anything different. Um, I have a good bit of squamous patients that do progress on their IO and they end up going into clinical trial, and they're going into clinical trial with combination IO. And so for that reason, I'm probably a little bit more likely to use a combination IO in the front line for those patients, knowing that their response is a little bit lower. But when we look at the 227 and 9LA data, the responses for squamous are clearly lower. But the hazard ratio is lower. It's a smaller patient population, though. So, I don't. Ultimately, there's nothing different to do right now. In the future, I don't know that may change. And this how does this stack up with our standard neoadjuvant chemo?
Yeah, I'll take that. How does it stack up? In our practice, we either decide at our tumor board whether this is a, chemo RT situation. I mean, these are usually 3B patients, single, station or not bulky disease where we think that chemo RT would be standard of care, but at the same time, they could be resectable. Those are the cases that we use radiation. And of course, if patients are expected to have pneumonectomy, we do not use radiation because we know that radiation does not work very well in this setting. So it's either neoadjuvant chemo or neoadjuvant chemo RT. I would not add immunotherapy to chemo RT like we discussed earlier. Any thoughts, Dr. Porter?
No, because I think we're about out of time.
Okay. All right. There are many other questions here, I think, but we can always address them. I'm going to, we can address via chat. But I would like to thank you so much for attending this session. And you should please head back to the agenda to join. I hope everyone had a wonderful weekend of learning, and we hope to see you again in person next year. There's one more session left, I think. See you all. Thank you so much for the very engaging session.
All right. Thank you.